So let's start with office blood pressure measurement, the classic method for defining hypertension. And this has been referred to as the cornerstone for hypertension diagnosis. This is because it's the most widely used in every setting around the world. It is often the only method available, and it's certainly the most well studied with the strongest evidence. We have to remember that the blood pressure classification, the treatment thresholds, and the treatment goals of therapy all are based on classic office blood pressure measurements. However, office measurements have serious limitations. First, it is the human observer, error, and bias. It is poorly reproducible. It can change from visit to visit without any change in treatment. It is reduced by placebo. It is subject to white coat hypertension effect and the masked hypertension effect. So even if you take careful measurements in the office, as we did in this study, and out of office with ambulatory monitored or home measurements, if you have many patients all together, you'll find a nice correlation with a high correlation coefficient. But if you're going to apply the diagnostic thresholds for each method, you'll find that some people have elevated blood pressure in the office and out of the office. This is so-called sustained hypertension. Some people have everywhere low blood pressure, normotensives, but there are people who have elevated blood pressure only in the office, the so-called office white coat hypertension, and some people have low office blood pressure but elevated out of the office, the so-called masked hypertension phenomenon. And even if you are very careful in applying all methods in the office and out of the office, there is disagreement between these measurements in about 30% of both untreated and treated individuals. And these are data from our center, on the left using ambulatory monitoring and on the right home monitoring. And you can see if you use ambulatory and home versus office, in almost 50% of the patients, the methods in the office and out of office agree. And for hypertension, and let's say 16, 18 for normotension. But you can see there is a considerable proportion of people, about 15%, who have white coat hypertension, and a similar proportion of people which have masked hypertension. So even with careful measurement, almost 1 out of 3 people, untreated or treated, have misleading diagnosis if assessed only in the office. Is that important? And this is a large data set by the IDHOCO International Home Blood Pressure data set in more than 6,000 people followed for 8.3 years. And you can see here in untreated and treated people, in untreated, you can see white coat hypertensives have slightly higher risk than normotensives, whereas among treated people, those with not well-controlled and white coat hypertension have similar risk. But what about masked hypertension? In untreated people, you can see masked hypertension have higher risk than normotensives and white coat hypertensives, and very close to uncontrolled hypertensives. However, if you look at treated people, the masked hypertensives among treated people have even higher risk than sustained hypertensives. This is because the doctor does not see the elevated blood pressure in the office and leaves these patients uncontrolled. And this is a case of a banker who attends our clinic in Athens, and you can see he has very high blood pressure at work, about 116, 117. When he goes to the doctor in a late evening visit, blood pressure is low, and home blood pressure is low, and nighttime blood pressure is low. So this person has specifically high blood pressure during work, which is hidden with home measurements or at the doctor's office visits. And this is a classic masked hypertension. And there are so many sources of error in this classic method we're using for so many years, which are related to smoking, caffeine, quiet room, temperature, sitting rest, talking between and during measurements, body position, device, and all these sources of error can contribute to misleading information with classic measurements. This is why Tom Pickering several years ago actually questioned the usefulness of measuring blood pressure in the office by the doctor, particularly because of the masked hypertension phenomenon, which is hidden in the office setting. So after so many years of using the classic office blood pressure measurement, we now realize that there are different types of office measurement, and we have to define them and describe the methodology for the proper interpretation. We have the classic office measurements in practice, which are auscultatory, and these are known to provide high values and overestimate blood pressure. We have office blood pressure measurements which are used with automated device. At least you take away the observer, you take triplicate automated measurements in the presence of the doctor, and these are higher than out of office, but still increase in the office. And we also have in clinical practice automated unattended measurements, which means that you leave the patient alone in the examination room and the automated device takes triplicate or 4 or 5 readings, and these are lower than the classic offered measurements. And of course, we have the auscultatory or automated research setting, very carefully standardized measurements in the office, which also underestimate office blood pressure. So when we are talking about office blood pressure measurement, we should carefully look about the different methodologies, devices, observers using in the office, and depending on these different methodologies, there are different thresholds for interpreting these measurements and different conclusions.